Hi, I'm Eric Prystowsky, and welcome to another episode of EP on EP. I'm thrilled today to have Dr. Jeff Healey with us, who is the Director of Cardiology at McMaster's University in Canada. Jeff, welcome to the show.
Hey, thanks, Eric.
So this is a very timely interview with Jeff because we're going to talk about anticoagulation in device-detected AFib. And Dr. Healey has just published a very important study, which we'll get into. But Jeff, let me take us all back a little bit. You know, we've been reading these papers of retrospective data, right, on all these studies. So give us a little historical perspective to this whole worry about subclinical AFib picked up on devices.
Sure. Well, we've been looking at these data for about 20 years, maybe a little longer. Patients with pacemakers initially and then defibrillators have short-lasting asymptomatic atrial fibrillation. And it's not rare. We see this in about 1 in 3 patients over time. And the question is, do we treat it or do we not treat it? And back when we first started seeing it, there was not a lot of enthusiasm to treat because we had warfarin, we had known risk factors for bleeding with warfarin, and so it was largely left. Then the DOACs came in on the scene and we again re-asked the question, could this be something worth treating? We knew the risk of stroke was there. Trials like TRENDS and ASSERT showed that there was a 2 to 3-fold increase in the stroke risk, but this was lower than clinical AFib. So this really led to the trials Artesia and NOAF because we knew we were dealing with a risk for stroke, albeit lower than clinical atrial fibrillation. So we had to again ask the question, does it make sense to treat these people with an anticoagulant?
That's perfect backdrop for you now going into the 2 trials. So there were 2 trials. You headlined the one, the Artesia, and then there was a NOAF trial. They were both published, not long from each other. And I remember reading them and trying to pin them all together, but this is your area. So can you help the listener with what were the similarities in the trials and maybe what were the major differences?
Sure. So they were both trials of subclinical atrial fibrillation, mostly short episodes lasting minutes or hours. They were both slightly enriched for age or, in our case, CHA2DS2-VASc factors. NOAA was a trial of edoxaban versus either a placebo or aspirin, depending on what patients were taking at the time of study enrollment. Our trial, Artesia, looked at apixaban versus aspirin alone, no placebo component, and that was reflective a little bit more of the difference, as you remember. In North Americans, we were more eager to use aspirin for low-risk atrial fibrillation, Europeans less so. So that's probably the most important difference. Okay. Our outcome was stroke and embolism. Their outcome included other things like myocardial infarction, pulmonary embolism, cardiovascular death. And so those are the big stroke differences in design. In execution, the trials were different size. Artesia was roughly twice the number of outcomes. It went much longer, and so more data points to analyze.
So to that point, a lot of us who've read both trials are left in a bit of a limbo because one trial that didn't go as long, the NOAA, was basically stopped for utility. Your trial showed some utility. Maybe we could discuss how much utility in certain groups, and I'm hoping you're going to educate us. So do you think, what do you think was the difference do you think was this the size or the duration?
Size matters here, and I think this was an issue of statistical power. Now, We've had a nice collaboration with the NOAA AFNet investigators. We have already published a meta-analysis a few months ago in Circulation. When you look at the 2 trials statistically, the results are the same. So they showed a trend towards a reduction in stroke that wasn't significant because it's a smaller trial with fewer events. But when you put the 2 trials together and line them up on a forest plot, the confidence intervals overlap, and applying a statistical test, the results are the same for stroke prevention. It's about a 35% reduction in stroke.
Well, let's get into that then. And one thing I want to clarify for me, I noticed that you couldn't have more than 24 hours. And in fact, if you did, that kicked you out.
Correct.
So that's interesting because I've tracked this stuff for years, and the duration in all these retrospective studies is literally across the board, 6 minutes to 24 hours. So can you tell us why you picked 24 hours?
Yeah, we had a ASSERT trial about 10, 15 years ago, and Isabel Van Gelder did a nice paper, and there seemed to be a step up in risk, as best as we could tell. It's very hard with trials even of thousands of patients to have a very granular assessment of burden. But at 24 hours, the risk seemed to approximate that of clinical atrial fibrillation, about 5% per year stroke risk. And so, again, because of our perhaps more hawkish approach to subclinical atrial fibrillation here in North America, the equipoise dictated that sites wouldn't enroll those patients, so we designed our protocol that way.
That was the main exclusion.
Main reason.
All right. Tell us the results that we didn't read. How's that?
Yeah.
So first, tell us the bottom line of your paper. I mean, I know those because I read your great study, and then tell us what you've been able to show since the original paper.
So the top line of Artesia was a 35% relative reduction in stroke, which was offset by a similar increase using intention to treat in major bleeding. And it's important when we look at these, we look at intention to treat for all the outcomes to compare like versus like. So you say, okay, you're trading off strokes for bleeds. So that's the headline, but it's not the full message. The strokes in Artesia were surprising to me. About half of the strokes were moderately or severely disabling or fatal. So using a modified Rankin score of 3 to 6, these are bad strokes that you definitely don't want to have.
Okay.
About half of the strokes were moderate to severely disabling or fatal. On the other hand, the bleeds, these are major bleeds using the ISTH definition, about 80% of them, patients walked away without dying or without requiring any surgical or procedural interventions. So there's also this weight of what was the consequence of these two things, that it's convenient to try and compare as equals, but I think in our practice, you ask a patient, do you want to have a major bleed tomorrow?
Yeah.
Do you want to have a disabling stroke? It's
No,
fairly
and that's
clear.
a very important point you just raised. Forgetting the trials, people who have clinical AFib, I have yet to have any patient turn down that decision. When you say, would you rather take a chance on a bleed that we can take care of or a stroke, I've yet to have any patient say, I'm afraid of
Me neither.
So I buy into that. But the thing is, that's your initial overall data look, right? Because that was your primary endpoint.
Sure.
But I know you've published some additional work.
Sure.
Can you educate us on the additional findings?
Yeah, so a lot of the additional findings were really geared at looking at subgroups, because the overall stroke rate for aspirin-treated patients was 1.26% per year. So it's not as high, it's as expected, not as high as clinical atrial fibrillation. It still falls nicely in the AHA, ACC, HRS yellow box of considered treatment in that 1 to 2% range, but it's not in the you got to treat these patients red box from those recently published guidelines. Right. And so the natural question is, okay, who benefits the most for it, and should we be treating those patients? So the first thing, like you and I presume, being electrophysiologists, does it have to do with episode duration and burden? And these data were presented at the European Heart Rhythm Association, and surprisingly, within that band of 6 minutes to 24 hours, there's no real gradient of risk. So you can have a single 6-minute episode, a bunch of 6-minute episodes, or episodes lasting 19 and a half hours. There's no gradient of risk. But I guess when you think about it, then there's two schools of thought. If it's a burden issue, we're all talking about something in the small, less than 1% burden. This whole range of 6 minutes to 24 hours, when you compress it onto a burden scale, it's a small range, and it's not much there. Second, as we have learned since medical school, longer episodes, maybe greater than 24 hours. We played by that rule for cardioversion and stroke risk and things like that. We excluded those very patients from Artesia, so we can't really comment on that. We think they're higher risk. This study does nothing to show it because we excluded them. But, perhaps this makes sense that in that range between 6 minutes and 24 hours, no effect. The one interesting fact is you could have your qualifying episode anytime before enrollment. And we look specifically at what your device had shown in the previous 6 months. The one group that seemed to have a bit lower risk is about the 15% of people who had no episodes in the 6 months prior to enrollment. And their risk seemed to be lower. So is there hope for ablation of atrial fibrillation, making it going away? Is there hope for strategies of intermittent anticoagulation? I think it's very premature for the latter, for example, but we did see this signal. It wasn't something we planned to look for, but it was something we found. So on the burden side, within that range, not much happening that can help us. That's the bad news. The good news is, on the other side, we can identify subgroups where there does appear to be a clear benefit. First one was presented just a few days ago in Europe at the stroke meeting. What it showed is if you look at the group of patients, and these were underrepresented in Artesia, but patients had a history of stroke or TIA, their risk wasn't 1.2% per year with aspirin. It was over 3% per year. Okay. And this risk was reduced by about 60% with apixaban.
Okay.
And so that's a massive reduction. It is associated with an NNT of about 25. The other early subgroup, which is presented today, looks at implantable loop monitors. We did have a sizable number of people who had their qualifying subclinical AFib picked up by an implanted device, a cardiac monitor.
Right.
Many of them were implanted for prior stroke, but the majority weren't actually. They were implanted for other reasons. And again, what we see, if you detect AF in that population and treat with aspirin, the risk exceeds 3% per year. And so it's a very high risk, and most of them do not have stroke. It's about 1/4 to 1/3 have a history of stroke. But what that group is enriched for, they have more vascular disease, more cardiovascular disease, less diabetes and hypertension, but they're more that flavor of patients. So the vascular type patient with a history of stroke, again, big risk and a big risk reduction.
So your data are really valuable. We're going to wait for more data to come out. But let me ask you just one last question to opine on. Your mean score, CHA2DS2-VASc, was about 4, as I remember, actually for both studies,
right.
Approximately 4. But we see a lot of patients who are CHA2DS2-VASc of 1 and 2.
Yeah.
So do you feel comfortable that your data can be slid down? I mean, there's always this trial slide, right?
Yes.
I'm a little uneasy when it comes to anticoagulation, but I'd like to get your thoughts on that.
Yes. So CHA2DS2-VASc has been a solid tool for the use in clinical atrial fibrillation. We are working for a more sophisticated model in these trials, right. Including echo parameters, blood parameters, these sorts right. of things. But this will be presented in the coming days. It will break the group up nicely into CHADs less than 4, equal to 4, greater than 4. And I will be...
To be continued.
I will be coming back, but I can tip my hat and say this will show a very clear result, not only on stroke risk, but on stroke prevention and bleeding. It will tell a very cohesive study. So I'm quite confident very shortly we'll have a much more satisfying answer for clinicians.
So this will be to be continued. We'll get you back.
You bet.
Jeff, thanks for all your hard work, and thanks for joining us.